Today, I'm going to talk about preconception genetic testing. And before talking about this specific test, let's see the slides. I'm going to make a little bit of introduction about general genetics in order to understand better what is this test about. First of all, I want to introduce the concept of a mutation. A mutation is a change in our DNA. In the DNA is written, and this is a damaging change. This change affects genes. A gene is just a subunit of our DNA that is having a specific function in our body. So these mutations can disrupt the normal function of this gene and cause a medical condition that we are going to call genetic disease or genetic disorder. We also need to know that we have for each gene two copies, one that we inherited from our mother and the other we inherited from our father. So the way these genetic disorders are transmitted through generations will depend on the kind of gene we are talking about. So we have, generally speaking, three ways of transmitting this disease. We have what we call autosomal dominant disease, meaning that an affected person inherits the condition from an affected parent, meaning that from the two copies we have of a gene, only when one is abnormal, one is mutated and it's not working properly, it's enough to cause the disease. So an affected child inherits this disease from an affected father or mother. Also, we have what we call autosomal recessive, meaning that healthy parents are carriers only of one single mutation of the gene, but this disease needs both copies of the genes to be abnormal in order to cause the disease. So these two healthy carriers, they are completely healthy, but they are at risk of having affected children. And also we have a third type that we call X-linked, that are conditions that are passed through a mother. A mother is having these X-linked diseases are affecting genes that are located in chromosome X, and women, we have two chromosome X, while men, they only have one. So a healthy or non-affected woman that is having no signs of the disease can be a carrier and then can transmit this mutation to their children, and their children can be affected, especially in that case, male, that they only have one chromosome X. Regarding the autosomal dominant diseases, we know that in a couple, in that case, the male, in the example I put here, we have that the man is affected. So he already knows he's having a disease and that has been diagnosed. So when he's planning to have children, he already knows his risk, okay? And a proper counseling regarding this disease should be provided to the couple. But what happened with the other two kinds of diseases, recessive and X-linked? We have that the couples are completely healthy, and most of these diseases, couples that are carriers, they are not aware of that. They don't know that they are carriers, and most of the cases they are diagnosed after they have an affected child of the disease. Okay. So, how can I know the risk I have of transmitting a genetic condition to my children? First of all, we have the scenario, and when I know for sure that there is a genetic disorder affecting my family, because me or my partner, we are affected of a genetic disorder, or because I have other family members. For example, I have a brother with Fragile X, or my sister is having a child with cystic fibrosis, etc. So I already know that there is a specific disease affecting my family. So when I'm planning to have children, I need to provide to my doctor all the reports I have, all the information, and the doctor will request for me and for my partner, if it's necessary, the specific genetic test for this specific disease, because since the disease is already in my family, I am at high risk of being a carrier. according to the results of the test requested, different scenarios we can have, and then a specific counseling and a specific reproductive options will give to me. But we have a second scenario when there is no family history of any genetic disorder, or at least I don't know if there is any. We have to consider that, as I told you, most people that can be carriers of a mutation that it's causing disease without knowing it. The average person can carry between 3 to 5 disease-causing mutation or variants, and the couple is at risk for recessive disorders, for example, if both members of the couples are carriers of a mutation in the same gene, in the same condition, and they have a risk of 25% of having an affected child. For this second scenario, these couples can benefit from a test that we call preconception genetic testing, that it's also known as carrier screening. This test is a genetic test that is done in blood, and it's used to determine if a healthy person can be carrier of a recessive or of its linked genetic disorder. So as I told you, if you and your partner both carry the same recessive mutation in the same gene, then you have 1 in 4 chances in each pregnancy that your child was affected. If it's an X-linked disease, the risks are different, but generally a carrier woman has a 50% chances of having a male affected, a boy affected of this disease. So this test, what it's doing is screening our DNA to detect mutations in different genes all at the same time, that we know that these genes are causing genetic disorders. This test, it's usually recommended before pregnancy, although it can be also done in early stages of the pregnancy. But ideally, it should be done before the couple is planning to get pregnant. Also, ideally, it's recommended to test both members of the couple at the same time. There are other approaches that they are testing only usually the female partner, and if they found any mutation in the female, then they are going to test the male for these specific genes. This can save money only if in the female you are not detecting anything. But if you are detecting several mutations, then you have to test the male, and at the end the cost will be the same, and you are adding more time to have the final result, because first you need to test the female, later you have to wait for the results, and later start the male genetic tests. So the ideal is to test both at the same time, because the test usually what is are giving you, it's what we call a matching report. That is, you have a report of all the variants detected or the mutations detected in the male, all the mutations detected in the female, and then they are making a matching report saying the specific risks for this couple. Because as I told you, for recessive disorder, you need that both members of the couple share mutations in the same gene to be at risk of having an affected child. So this test can be recommended for any couple without family history of any genetic disease, but that they are concerned and they want to know their genetic risks for their offspring. Also, there are some specific subgroups of population like that are at increased risk of specific disorders. And one are specific ethnic groups. We know that some genetic disorders are more frequent in some populations. So individuals belonging to these populations, they have an increased risk to carry this specific genetic disorder. Another subgroup of population that are at higher risk are consanguineous couples. So we know that these consanguineous couples are descending from a common ancestor. And for example, first cousins share 1/8 of their genes. So consanguinity increases the risk of the couple of having children affected of autosomal recessive conditions. And consanguinity, it's quite frequent in some regions, in some parts of the world. So this test, the preconception genetic testing or the carrier screening test, helps couples, once we have the result, to make informed choices regarding their family planning. They can decide to go for a natural pregnancy with a prenatal testing, and according to the results, they will take the decision they consider. Also, they can decide to do an IVF cycle with a PGD. It's a preimplantation genetic testing for this specific disorder in order to select the embryos that are free from the disease, that they are at risk, and transfer only the healthy ones. Also, they can decide to go for egg, sperm, embryo donation, or adoption, depending on the legislation of the country, obviously. And also, they can prepare for management of an affected pregnancy and a children if they want to go ahead with a pregnancy without any test. There are two types of test of preconception genetic testing. One is what we call target genetic testing, that tests for specific disorders based on your ethnicity. If you belong to a specific ethnic group that has higher rate of carriers for a specific genetic condition, just testing you for these specific conditions, it's recommended. Examples of that, we know for example that Tay-Sachs disease has a higher carrier rate among Ashkenazi Jewish. So if the parents belong to this population, the carrier screening for this Tay-Sachs disease is recommended. Also another example, for example, there is a small area in a small village in Quebec, in Canada, where has been observed a high rate of very rare genetic diseases. There are a lot of carriers of these genetic diseases. So it's recommended on people that it's from there or they have ancestors from this area to test for these specific diseases before having children. However, this is not very easy sometimes to know your ancestors because sometimes you don't know. Nowadays there are big migration, inter-ethnic marriages. So establishing your ethnicity, because all of us, we are a mix sometimes. So for this reason, they develop what we call expanded genetic carrier testing, that it's a more comprehensive carrier screening that is designed for all kinds of ethnic groups. It includes a lot of genes, genes that are mutations that are frequent in all populations worldwide, and also genes that are more frequent in specific populations. So this test can be applied to everybody independently of their ethnic background. And this is done by NGS technique. And in a single test, we can test hundreds and hundreds of genetic disorders. I put here in this table an example that this is quite old because it's from 2017. But it's like an example. Nowadays, there are a lot of companies that are develop their own panels, the expanded ones. But this is an example of, you can see that the panels on the tests in the market are different one from each other. So some of them are including more genes, other less genes, and the genes that they are included are not always the same. What it's recommended is that the genes that are included in these panels should be clearly related to a genetic condition, to a disease. And the frequency of this disease should be already known in the different populations, because you have to choose the diseases that are more frequent, or that you can find more carriers. If you have a disease that only 1 or 2 people in the world has been described with this disorder, maybe it has no sense to include this gene in the panel because the chances of finding a carrier are extremely low. Also the conditions.
Hello, Dr. Carmen. Can you hear me? Japneet? Vishnu?
Yes, I can hear you, ma'am. I can hear you.
Yes.
Yes, I can hear you.
Yeah, Dr. Carmen froze, right?
Yeah.
Dear participants, I think Dr. Carmen has just had some technical issue. Just wait for a second. We will see how we can resolve it. Dr. Carmen? Hello? Dr. Gautam, can we start yours? Because I think she got disconnected. Maybe she will join us again.
Perfect. No problem.
Because there are 159 people, we don't want them to be waiting. Sorry, I believe Dr. Carmen would have had some technical issues. She got dropped off. She will join us, but she had last 2 slides left. So I would request Dr. Gautam to start talking, and then maybe when she joins, we can take it in the end, the last 2 slides. Sorry for the inconvenience, everyone.
Is my screen seen?
Yes, doctor.
Okay. So this webinar today is essentially for patients, but I have seen the audience and it's a mixed crowd of physicians and patients. The same lecture can be tailored for medical professionals. So there might be some slides which have medical terminologies. I'll try to simplify the slides. So essentially, this is a very common condition, PCOS, and in a tertiary OPD like ours, we see 1 in 5 patients in a country like India. We have a PCOS, and in the UAE, 1 in 3 patients turn up with PCOS and fertility problems. So we will take you through, the entire subject, including the treatment. So please try to understand PCOS or polycystic ovarian syndrome is an endocrine disorder. It's a hereditary disorder, probably transmitted through the maternal side of the family. This syndrome is manifested by endocrine and metabolic dysfunctions, which markedly change the ovarian environment. And essentially, these medical terminologies or mutations, etc., mean that the eggs that are produced in polycystic ovarian syndrome patients have a higher than normal incidence of chromosomal abnormalities or genetic abnormalities. So when we try to do any treatment for PCOS subjects, especially now that genetics is come into IVF, we find that there is a very high number of immature eggs, poor quality eggs, decreased rates of fertilization in IVF. These eggs, if they fertilize, sometimes get arrested on day 2, day 3. Day 5 means blastocyst or blastulation. They don't go up to day 5. And many a times the blastocyst quality is not very good. When you compare this to normoresponders or non-PCOS women, so there is less implantation and higher rates of miscarriage. So we are looking at what used to be a very difficult group of patients to treat. Now with pre-implantation genetic testing in our armamentarium, results are much better and almost similar to non-PCOS subjects. Also, a patient must remember that PCOS may be a risk factor for development of type 2 diabetes, heart disease, and hypercholesterolemia. That means elevated cholesterol levels. What is very important to understand is that women with PCOS have at least 7 times the risk of myocardial infarction and ischemic heart disease by the time they reach age 40. And 40% of these women will have type 2 diabetes or impaired glucose tolerance. Research done over the last 20 years has shown us that the application of diabetes management techniques which aim at reducing insulin resistance and hyperinsulinemia, such as weight reduction, and the administration of anti-diabetic tablets can not only reverse testosterone and LH abnormalities, but can also improve glucose, insulin, and lipid profiles. Again, in layman's language, that means that once you have to first diagnose that the patient is PCOS. Generally, if there are two reproductive hormones, FSH and LH, in PCOS women, when we test for these hormones, LH in normal responders or normal women, FSH to LH ratio is 2:1. In PCOS, the ratio is reversed. That means LH is always more than FSH. So one is you do the baseline test, you find the reversal of ratio, you find enlarged polycystic ovaries with multiple cysts throughout the stroma or peripherally arranged. So first thing is diagnose PCOS, and the second is do a 12-hour fasting insulin. So the easiest but least sensitive measure of insulin resistance is fasting serum insulin. So a very simple test is, once you have diagnosed PCOS, call this patient with a strict 12-hour fasting. If this 12-hour fasting insulin level is more than 10, then the patient requires an anti-diabetic drug. That means it requires the simple tablets called glycophage, glucophage, metformin. Between 10 to 14, it indicates mild insulin resistance, and over 14 indicates severe insulin, moderate and severe insulin resistance. What used to happen is that in the early 70s or 80s, when these adolescents or working women with PCOS used to go to gynecologists with symptoms of irregular menses, which used to be distressing. They would not get menses sometimes for 2 months, 3 months. The primary treatment to get the menses regularized was give them a birth control pill or a combined oral contraceptive pill, just so that they get their periods every 28 hours. But today, recent studies have said that because 70% of lean PCOS subjects, that means 70% of women who are thin and 90% of women who are obese have insulin resistance. And if you give these birth control pills which contain steroids to such women who have a diabetogenic tendency, whenever you give steroid to somebody with diabetes, it flares up the diabetes. So similarly, if you give these women simple birth control pills, steroids, just to regularize their menstrual cycles, it has a devastating effect on their glucose tolerance. And this study shows that 16 non-diabetic hyperandrogenic or PCOS women treated with combined oral contraceptive pill had significant deterioration in glucose tolerance, with 2 women even developing frank diabetes. So this raises doubts about the short and long-term safety of ovarian suppression with oral contraceptives. Today, we do not recommend steroid use once you have insulin resistance. It's common sense that in diabetes, you don't give steroids. It flares up the condition. Metformin, on the other hand, is a safe, effective oral medication which increases the action of insulin at the peripheral cell level, decreases hyperinsulinemia, reduces the male hormones, and in fact corrects the whole biochemical domino effect. Once you start metformin, you can start it even with the onset of menses. This is taken almost throughout life. Metformin is given in a dose of 1.5 to 2.55 grams per day and can safely correct PCOS in non-diabetic as well as diabetic women. But you have to document insulin resistance before you start. Metformin therapy has 2 major effects. It reverses all the hormonal abnormalities of PCOS and also has a reduction of weight and excess body hair. But that does not mean that, just because you are a little obese, without checking for insulin resistance, you must take any drug like this. Metformin reduces the otherwise long-term risk of heart attack and stroke. And when you have insulin resistance, we advise once a year, check your biochemical levels, but continue metformin throughout life. Once a patient gets pregnant, these PCOS patients have a slightly higher incidence of first trimester miscarriages. So should metformin therapy continue during pregnancy? And what blood test should be done during pregnancy to decide if it should be continued? Previously, we used to think it is the male hormone and the excess of LH that gives rise to these early first trimester miscarriages. But now we know that it is mainly because of a hormone called plasminogen activator inhibitor. So let's not get into medical details, but metformin decreases this hormone and prevents first trimester miscarriages. It is non-teratogenic, safe, and can be continued throughout pregnancy. This is how a typical polycystic ovary looks like. And when a patient with fertility problems comes to us, we generally, this is a baseline profile that you do on first, second, third day of her normal menses or her withdrawal bleed. That means withdrawal bleed is when we give her progesterone to induce a withdrawal bleed with secondary amenorrhea if she's having irregular menses. So you do an FSH LH. In PCOS, LH is always going to be more than FSH. You always check for TSH. 1 in 5 patients will have some thyroid abnormalities. You check for anti-thyroid antibodies. You check for prolactin. AMH is the main reproductive hormone, anti-Mullerian hormone. Normal levels are 3 to 8. In PCOS, it's always more than 8. And the higher the AMH, the more is the severity of the metabolic syndrome. Vitamin D today is a very important hormone. And 12-hour fasting insulin to decide if the patient will require to start metformin along with her fertility treatment. This 12-hour fasting insulin, again, is very important. It has to be a true 12-hour fasting insulin. If more than 10, then metformin needs to be started. The last thing is not a blood test, it's antral follicle count. So if we go back on to this slide, normal antral follicle count means on first, second, or third day of menses when you do a vaginal ultrasound and scan each ovary separately. These are antral follicles that you see, these dark areas. And if you count each of these dark areas on this slide, it's 13 to 14. So that means this is a polycystic ovary. In a normal woman on first, second day, you should have about 5 to 7 antral follicle counts. So these are a larger number of antral follicles. This is another way you diagnose polycystic ovarian syndrome. Vitamin D today is considered to be very important, and especially women with PCOS who are not getting pregnant should have a vitamin D level. If you see the line, second line at the bottom, should be more than 30 nanogram per ml. So even as patients, you can take care of yourselves and ensure that when you're trying to get pregnant, your vitamin D level should be more than 30. You must tell your family doctors to give you supplements if your vitamin D levels are lower. The first line of treatment for PCOS subjects, if their tubes are open, husband's count is all right, is ovulation induction or controlled ovarian stimulation. And clomiphene citrate, or Clomid, as is known in most parts of the world, is still the gold standard in 2020. We always give a withdrawal bleed, and remember the dose is 50 to 100 under medical supervision. Please do not take any medication like this without a gynecologist or a fertility specialist supervising. If there is a prolactin excess, you begin something called cabergoline or Dostinex, which is the brand. And only if you have to do an ancillary procedure like IUI, then we give some sort of trigger. If Clomid is used alone, you don't need any trigger. Clomid induces its own endogenous LH surge and you don't need to do anything. Usually no luteal support is necessary when you use clomiphene alone or you use HCG. Only when you use something like a GnRH agonist, then you need to use luteal phase support. Again, this tablet Clomid or clomiphene can be used in combination with injections to increase the pregnancy rates and to do an ancillary procedure called IUI. We have been covering these separate topics in previous seminars, and we'll be covering IUI again, I think, next month. So this is a slide that tells you how the tablets are taken and For the medicos, the medical professionals on the webinar, an extended Clomid protocol is clomiphene citrate day 2 to day 6 can be extended from day 7 to day 11. And once you have a 22-23 millimeter dominant follicle with a triple layer endometrial morphology, endometrium, only then you can trigger for whatever treatment. So this is called a sequential clomiphene and gonadotropin cycle. That means you combine tablets, and this gray line is injections. This doubles the pregnancy rates. And but remember, all these things you can do maximum 3 or 4 times. And you have to go to a very experienced person when you have PCOS and you start using injections, because there is a finite risk of ovarian hyperstimulation syndrome. In layman's terms, we aim for 2 or 3 eggs, maximum 3 eggs. Like in a country like UAE, if there are more than 3 follicles, the cycle treatment is cancelled for a PCOS woman to prevent, one is multiple pregnancy, and we don't want ovarian hyperstimulation. So if the dose is correct, the doctor has given the correct dose and the body responds with 2 or 3 follicles maximum, then you can do an IUI. When there are a larger number of follicles each time you attempt to stimulate these PCOS subjects, the ideal treatment is IVF. So how do I manage my PCOS patients? So you diagnose PCOS. So diagnosis should be, one is with ultrasound, but that is subjective. That means somebody looks at the ultrasound. You must always complement it with an objective diagnosis by doing the hormonal profile that I showed you. The levels of LH should be more than FSH, AMH should be more than 8. Then always do a 12-hour fasting insulin. If more than 10, initiate metformin twice a day. You know, first you start once a day. The common side effect is not diarrhea, but loosely formed stools. After the body gets used to this medication, increase the dose to twice a day. And you can add 200 micrograms of chromium picolinate, which also potentiates, so does the same action as metformin. So it brings down the insulin levels. Minimum 1 to 3 months of metformin therapy before you start any treatment. And these are technical things. It doesn't matter what injections you use. You have to use them under medical supervision. And once the patient gets pregnant, please repeat the serum insulin. If more than 10, continue the drug into pregnancy. Retrosol is another drug that was introduced to combat this problem. But today we know the quality of evidence of using Retrosol is low, and Clomid is still the gold standard. Also, for the medical professionals, you must remember 18 millimeters is not the correct follicular diameter on transvaginal follicular studies. More than 21, 22, we personally I trigger after 22 millimeters, we trigger ovulation, because you have more mature oocytes at larger follicular diameters in PCOS women given clomiphene. And when you talk of, remember, an IUI has just 20, maximum 25% success rates. But today, for PCOS women with IVF, we have a benchmark 70% clinical pregnancy rate. So ideally, if a patient can afford it, the patient must resort to IVF early and complete her family. And we only use an antagonist for PCOS ART cycles. Again, this is the type of medication that prevents a life-threatening complication of stimulation called ovarian hyperstimulation syndrome. And a lot of women, patients, doctors ask us at webinars about acupuncture for PCOS. Remember, PCOS is a genetic disorder and acupuncture is not going to cure it. So there have been now many studies, and the Cochrane database from UK reviews all the published literature on acupuncture for polycystic ovarian syndrome, and there is insufficient evidence to support the use of therapies like acupuncture for treatment of fertility in women with PCOS. So what is the take-home message? Understand this. This is even for practicing gynecologists. PCOS women are the most difficult group of women to treat, and gynecologists without an IVF lab backup are scared of a life-threatening complication called ovarian hyperstimulation syndrome. It is ideal that they refer these patients to a fertility center for management. So practical management of these patients remains difficult. Today, when we do IVF, ideally we can do minimal stimulation, and to prevent OHSS, we use something called an agonist trigger. And then we never do an embryo transfer in the same cycle. We do something called a freeze-all. That means all the embryos generated are grown to day 5. When they are 5-day-old embryos, you freeze all of them. Ideally, again, in a developed world and patients where patients can afford it, a pre-implantation genetic testing for aneuploidy or a PGS, a pre-implantation genetic screening is done. And then only a single frozen embryo transfer in the next month can give 70% pregnancy rates. Just by introducing pre-implantation genetic testing into our clinical protocol, we have been able to breach even the 70% clinical pregnancy rate and gone up to 80% clinical pregnancy rates in such patients. And you can all, because we do the embryo transfer in a remote cycle, that means not in the same cycle where the eggs are retrieved, we actually eliminate the excessive ovarian response and our IVF cancellation rate. Today, for me, the pillar stone of success is achieved by pre-implantation genetic screening, followed by a frozen embryo transfer, where you can prepare the endometrium of the recipient and give us very, very high pregnancy rates. And with additional data now coming in the 2020s to support this trend of IVF with pre-implantation genetic screening, a new IVF paradigm is evolving. The days of transferring 2 embryos and 3 embryos and 4 embryos are gone by. They're 20 years old, 25 years old. Today, we just transfer a single genetically screened, genetically healthy baby in a FET. That means frozen thawed embryo transfer in a separate cycle where you can artificially prepare the endometrium and transfer your frozen blastocyst, which is screened and found to be chromosomally normal. So applying this technology to a PCOS patient may provide the optimal outcome for many patients. For those of you who are attending this webinar and want to know more about it, please follow our Instagram channel, where we have put up short clips, movies, and new publications on the use of PGTA and FET in increasing success rates in PCOS subjects. Thank you for a very patient hearing. We will finish Carmen's lecture and then go back to the questions.
Thank you, Doctor. And Dr. Carmen is back with us.
Yes.
So, Doctor, you want to just finish your presentation and then we can go to the Q&A.
Yes, 1 second. I'm trying to start my video. Can you, okay. I don't know what happened. I'm sorry, because I suddenly was out of Zoom. So I don't know what happened. Let's share my screen. I don't know if this is the last slide you saw, because I didn't realize when I was out. This is.
Oh, it was the previous slide. Yeah, this was the last slide.
It was the last one. Okay. So this here, it was like an example, as I told you, in all the reports, they have to include all the all the genes that they are testing, also the conditions that are related to these genes. Also, as I told you, we need to know the carrier frequency. Of some of them we don't know, but if it's known, we have to include the carrier frequency. And also the ethnicity in which this disease is more frequent. As you can see, all the tests are including genes that are very frequent in general population, but others are also only frequent for a very specific kind of population. Anyway, this is called a universal test, so it can be used for all kind of ethnic population. See, this is another brand of the test, and they also include all this information. It's very important to know the genes that are included in the test. Since I told you that not all the panels available in the market are including the same genes, if we are testing each member of the couple with a different panel, maybe you are not covering the same genes. So if the results in the male, for example, it's negative, and in the wife, it's positive, and they found a mutation in a gene, we need to be sure that the negative test of the male, it's also testing all the genes that are included in the female, because if not, then we can find this couple is not having a risk, but this is not true because we are not testing the same genes. So still there is a risk. So it's very important, for the reason I recommended, to test both members of the couple with the same test, with the same brand of the test. And if not, if it's not possible, if it's not available because it was done previously or was in another time or in another country, we need to check the genes that are included to be sure that when we are giving them, you don't have risk or this couple is not having risk, it's true. Regarding the results, there was a paper published in 2013 that they test more than 23,000 individuals. They test for 108 genetic disorders, and they found among this population that 24% of them were carriers for at least one disorder, and more than 5% of them, they have more than one disease. You can find here carriers of 1, 2, 3 diseases, 4 or more diseases. So also the percentage of carriers detected in the different subgroups of population were different. And usually the populations with higher rate of consanguinity, they have a higher rate of detection of carriers, okay? And also here they describe the number of couples, they are at risk of having affected children because both members of the couple are sharing mutations in the same gene. So it's very important to do a genetic counseling before and after the test, as in all genetic tests. Before the test, we need to explain to the patients what we are going to test, the use. It's impossible to explain to them all the genetic diseases that are included in the test because usually are hundreds, but it's interesting to classify them. For example, we are going to test some genetic disorders related to intellectual disability, like Fragile X, or diseases that are shortening the expectancy of life, like spinal muscular atrophy, etc. Give them the type of diseases we are going to include in the test. Also, if we have late onset genetic disorders, etc. Saying that, also the post-test genetic counseling obviously is based on the results we have. We are going to provide a specific genetic counseling for the specific risk, if there is any, for the couple, and then explain them their specific reproductive options. We have to say that these tests have some limitation. It's not that we are doing this test and we know for sure that we are not going to have any children affected of any genetic disorder. This is not true because 100% certainty in science, it's never like that. Because first of all, we are not testing all the diseases, all the genetic diseases that are known. We include, or this test includes, usually the most frequent one. Even if they include 1,000, it's not all the genetic disorders that are possible. Not always all the tests are covering the 100% of the gene. Most of the panels are only including the most frequent mutations in the gene. There can be others that are very, very rare. Also, we can detect some variants or some mutations that we don't know the significance of them, meaning that they have been described, but we don't know if they are really causing a mutation, causing a disease, sorry, if these mutations are disrupting the function of the gene or simply are variants that are doing nothing. And it's recommended only inform the mutations that we know for sure that are causing disease. But what happened that maybe this is the knowledge we have today, but maybe these variants can be reclassified in future and classified as pathogenic. So this information will be missed because in the report, these variants are not shown, are not recommended. Also, negative results cannot guarantee a newborn free of a genetic disorder because the genetic disorder can be produced de novo in the embryo. It means it's not an inherited disorder. It's just a mutation that is produced de novo for a dominant disorder in the child. There is mosaicism, etc. So this test, what it's doing is lowering the risk for this couple compared with the general population. But there is still a residual risk, and this is very important to have it in mind. Also, we need to counsel the couple that when an individual is found to be a carrier for a genetic condition, his or her relatives are also at risk of being carriers, and it's and we always try to encourage this couple to inform the other family members, especially their siblings that usually are also in a reproductive age. And this is very important because genetic conditions are usually not affecting only an individual, but are affecting the whole family. So to finalize, in summary, we can say that this preconception testing or carrier screening is a test to detect if a person or a couple is carrier of a recessive disease or an age-linked disease when they are not a priori at high risk because there is no personal or family history of any genetic disorder. The main goal of this test is to facilitate informed reproductive decision-making. As I told you, there are tests that are targeted specific for a specific disease based on ethnicity. However, nowadays it's recommended to do expanded, that we call pan-ethnic or universal test, that covering, because as I told you, sometimes it's very difficult to establish the ethnicity or the background of a person, and we all are a mix of different ethnic groups. Also, this test is recommended during the preconception period, and it's very important because we have more time to take decision. If you are already pregnant and we have to extend this test, do a prenatal testing or whatever, we don't have time. And it's very important that the couple know the results before deciding to get pregnant, and then they can choose IVF, prenatal testing, whatever the decision they want, but we have time. Also, it's very important to do a pre and a post-test genetic counseling, explanation of the test, the kind of diseases that we are including, also obviously informed consent, and also the implications that these results can have to other family members. And thank you very much for your attention.